I think we're going to go ahead and get started. I want to thank Ms. Young for participating in this and taking the time out of her day to come to speak to us. She's going to be speaking to us about her work in advocacy. We Just to kind of inform you, Ms. Young, we sent out the link to your podcast episode that you talked on. I forgot the name of it. I'm sorry. So people kind of know a little bit about you, but if you want to start with kind of introducing yourself, that would be great.
Hi, everybody. The podcast I think you're referring to is Read Scholars. My friend, Dr. Mary Fleming, is the president of Read Scholars. So I was happy to help her out with that podcast episode. But yeah, I am Kinika Young. I am an attorney and I work at the Tennessee Justice Center in Nashville, Tennessee. I'm originally from Montgomery, Alabama, and I went away to college at Florida A&M University. I actually ended up at Florida A&M because I knew I wanted to go to law school, and they are the top feeder school for Black lawyers going, like sending Black students to law school. So they had a really strong pre-law program, and that's why I ended up choosing FAMU, and I'm a proud Rattler. And from there, I went to Tulane University for law school and got to really know New Orleans and the culture and the community there. And Hurricane Katrina actually happened. I don't know if you guys are old enough to even remember Hurricane Katrina, but that happened during my third year of law school. And I evacuated, as most people did, and ended up in Nashville. At that time, I had clerked for a law firm here, and they helped me get set up to go to Vanderbilt University as a visiting student for that, what we call the Katrina semester. And so I was at Vanderbilt University Law School for the fall of 2005. And then I went back to New Orleans and finished up my law degree there and graduated in 2006. And then I came to Nashville and started my practice at the firm that I had clerked for. And I was there for 10 and a half years and decided that I wanted to do more social justice focused work. I was really hit hard by the tension and civil unrest that was happening leading up to the 2016 election. I recognized that when our current president won, that a lot of things would change for low-income people in particular is who I was concerned about, particularly Black people. And I wanted to try to minimize the damage that I saw coming from his administration. So I came to the Tennessee Justice Center, and here I work on health policy issues, mainly trying to educate Tennesseans about the role of safety net programs in our state, how even people who are not low income should care about Medicaid and the Children's Health Insurance Program, and other assistance that the state provides to low income people who are disproportionately people of color, relying on those programs. And so I spend most of my days really trying to get people to see the big picture and to get connected to advocacy around the issues that impacts our entire communities. So I don't know if you want me to stop there or go into the topic I was asked to talk about.
Oh, I think that's a good segue to go into that topic. Thank you so much for that introduction, though.
Cool. So I was asked today to talk about health disparities related to COVID-19, especially how the virus impacts the Black community and Medicaid expansion as a vehicle to increase access and improve outcomes. So I guess I'll start by saying, unfortunately, healthcare and the virus are political issues for better or worse. We're kind of a very polarized country right now. So even basic things like healthcare and public health information have become a red and blue issue. And so I'd start out by saying whether or not you like politics is irrelevant because these issues impact your life and you really can't ignore them. It's really unavoidable to get involved with politics. And so I laugh when people say they don't like politics because I'm like, it doesn't really matter how you feel about them. Politics are like bills, they exist and you ignore them at your own peril. So you really have to pay attention and get involved. And doctors, I think historically and today, have had a really big influence on healthcare policy. I think it was in Tennessee in particular, there were a group of over 1,000 doctors who participated in a sign-on letter to convince the governor finally issue a state or safer at home order and to implement some of the public health measures that national experts had been advocating for months or weeks actually at the start of the pandemic. And so the role of doctors in healthcare policy can't be understated. I also, would like to ground the conversation in like historical reference. COVID-19 is not the first public health crisis or epidemic to disproportionately affect people of color in this country. You'd actually have to go back to the Civil War era when there was a smallpox epidemic that was ravishing low-income communities, not just Black people, but also poor white people. But at that point, Black people were in servitude and did not have access to basic sanitary living conditions, clean water, safe shelter that was free from rodents and fleas and other disease carrying animals. And so when the smallpox epidemic first hit that community particularly hard, some people, in particular politicians, looked at that as some indication of the inferiority of Black people. And that mindset has carried forward in our healthcare system, even to this day, with some people thinking that Black people are more susceptible to the COVID-19 virus because of some biology, which is absolutely not true. The COVID-19 pandemic has hit the Black community and Brown community particularly hard because of the social determinants of health that have never been addressed adequately in this community. Particularly when you see greater exposure to the COVID-19 virus, that really explains why Black and Brown people have infection rates 3 times higher than white people here in Tennessee. And I think those numbers kind of are similar across the country. That greater exposure is linked to social factors like employment. Whereas 43% of Black and Latino people work frontline jobs, meaning they cannot telecommute, they cannot sit on a computer and do their jobs like I do every day. Compare that to 25% of white people who have those frontline jobs. And so right there, you have a disproportionate number of people of color who are exposed to the virus just by virtue of their employment. And then you also have factors related to income status. Black people are more likely to be uninsured than white people, meaning that if they are sick, they're less likely to immediately go to the doctor because they cannot afford the medical bills that they would incur from going to seek treatment early. And they also are more likely to work jobs that do not offer sick leave, paid sick leave. And so if you have a situation where you are fortunate enough to have a job, but you don't have paid sick leave and you don't have health insurance, you're going to tough it out and go to work even if you're not feeling well. That leads to more people being infected. And so when you have clusters happening in Black and Brown communities, it's because of that exposure and it's because of the absence of those benefits that would help them to be safe and not have to expose themselves and expose others to this virus. You also have to factor in other characteristics of low-income communities, meaning they are more likely to take public transportation. And so the more you're engaging with the public, the more likely you are to be infected with a respiratory airborne virus. Also, because of limited income, it's more likely that people of color will live in households with multiple people, often 3 generations in the same household, because housing is not affordable. And so you have more people trying to live together to reduce that cost burden on the family. And so that makes it nearly impossible to isolate or to really keep away from people and minimize that exposure to the virus. There's also been in communities of color noted barriers to accessing testing and treatment, particularly here in Tennessee. For a period, there were testing sites that were up and running in white neighborhoods when Black neighborhoods did not have the same testing sites. So they were not able to go out and get tested early and figure out, you know, who has the virus and how can we implement some public health measures to keep it from spreading to others. Um, and so looking at, all of these different factors, it explains this higher rate of infection. But then when you look at the higher death rates, there are other issues at play there that drives the fact that Black people and Hispanic people are twice as likely to die from COVID-19 as white people. And that can be traced to those underlying health conditions, but also to the delayed treatment. There have been examples, countless examples in the news of people of color going to the hospital, requesting care, requesting to be admitted and being sent home, either because they don't have health insurance or because the hospital may have been understaffed and they're rationing care. And usually those are the people who get the short end of the stick when resources are limited. And so all of these social factors can be directly tied to racism. And that is a point that I make in a white paper that I wrote. I'll put the link in the chat for people who like to read, but so you can check that out and learn a little bit more about how the health disparities that are playing out during this pandemic are tied directly to racism and the history of how this country has come about in terms of creating a really unequal healthcare system. And so solutions. My main focus is trying to advance healthcare policies that can really address health disparities and create health equity, meaning that everyone has access to what they need to be healthy. Um, Medicaid expansion is one of those tools, and it's the tool that we are focused on here in Tennessee because we are one of 12 states that has still not expanded Medicaid under the Affordable Care Act. I assume you guys are familiar with that as medical students, but basically we have a coverage gap in states that haven't expanded because our Medicaid eligibility rules only go up to a certain level of the poverty level, and the Affordable Care Act individual marketplace kicks in at a higher level. And that gap are people who don't qualify for Medicaid and they can't afford to buy a plan on the marketplace because they don't qualify for those subsidies that were offered under the Affordable Care Act. The decision to not expand Medicaid, I also argue in the paper, is tied to race because some leaders, some politicians view public benefit programs like Medicaid as welfare instead of viewing it as health insurance. And so they're totally fine with funding employer-sponsored insurance and providing tax subsidies to employers to do that, which is our tax money being, used for that purpose. But when you look at providing, tax money to fund a health insurance program for low income people, then it becomes a government handout and it's not popular. And so trying to change the mindset of people and how they view Medicaid is one of my priorities. And so we try to educate people about the benefits of the program and put a face on who is enrolled and who actually prospers from having access to this money. So Tennessee in particular has foregone $1.4 billion with a B each year that it has not expanded Medicaid. That is money that would provide health insurance coverage to over 300,000 people in the coverage gap. Tennessee has the highest rate per capita of rural hospital closures in the country. We've had, I think, 13 hospitals closed since 2010. Texas has a higher number, but they're bigger. So per capita, Tennessee is really, doing poorly in that area. And so Medicaid expansion has been shown to make it 6 times more likely that a hospital will not close if they have access to that funding, because they can reduce the uncompensated care that they have to provide in the community if more people have health insurance. There was also a study done a couple of years ago that showed that Medicaid expansion in Tennessee would generate 15,000 new jobs in the healthcare sector. So these are really important benefits that people need to be aware of that we're missing out on by not expanding. Medicaid expansion also, is important for people to understand that we're talking about working adults here. We're not talking about people who are just trying to live off the government. These are people who work long, hard hours and do not have health insurance because their employers don't offer it or it isn't affordable to them. And so I think the pandemic has also created an opportunity to show people that our system is broken when you tie health insurance, health coverage to employment, and then deny the types of employment that come with those benefits to certain people. You're, at the core of creating an inequitable system. And also it's a flawed system because, as we've seen with the rising unemployment, when people lose their jobs through no fault of their own, they lose their health insurance as well. And so we know that in Tennessee, an additional over 120,000 people have lost health coverage due to job loss just between February and May of this year. And that brings our state's total uninsured adult population to over 750,000. And across the country, an additional 1.9 million Americans who previously had employer-sponsored insurance and lost their jobs are projected to fall into the coverage gap by next January. And so Medicaid expansion would be a really important intervention to catch those people who are losing their employer-sponsored coverage so that they can continue to get the comprehensive care that they need and also be protected from financial ruin if they were to become sick and have to seek medical care and pay out of pocket for those costs. So Medicaid expansion would provide access to health care for people who don't have employer-sponsored insurance and can't afford to go into the individual marketplace and buy their own plans. Studies have shown without steady coverage, Black and Hispanic people are unable to develop and maintain long-term relationships with their physicians and are less likely to receive trusted medical advice, which is particularly important because of the history of mistrust and distrust that's been sown in our healthcare system because of abuses that have been perpetuated against Black people, specifically with experimentations such as the Tuskegee syphilis experiment, and also with taking measures without informed consent from people. One of the most notorious examples would be the story of Henrietta Lacks, whose cancer cells were taken in and experimented on without her knowledge or consent, and have been really the backbone to modern medicine as we know it today. And she never got her credit for her contribution to that. And so Black people are aware of these transgressions and they don't trust the healthcare system. So making sure that people have access to coverage so that they can develop relationships with their healthcare providers is really important. And I think it's also important that more Black doctors practice and serve the community in that way, because it's been shown that outcomes improve when there's what's called racial concordance. That's where the patient and the doctor are of the same race, particularly in the area of maternal and infant health. There was a recent study that showed that the outcomes for infants have been improved, or results show that they were less likely to have infant mortality rates when the doctors were of the same race, particularly Black, when they were treating Black babies. And so that's something that I think you can't ignore in terms of the impact of race in the provision of healthcare services in our country. And so providing that steady coverage, encouraging more Black people to enter the medical field is something that is important to create this environment where Black people are viewed as human and as deserving of care, and having the resources to seek preventative services and to have consistent care to manage chronic conditions, which are essential to both physical and mental health. And so because of all of that, increasing the rates of insurance can increase access to regular care, and that would help improve health and reduce health disparities for Black communities in particular. And in states that expanded Medicaid, racial disparities concerning access to care have been reduced as Black people have gained health insurance. So we are pushing Medicaid expansion as one tool. It's not a silver bullet, but it's one tool that can help address health disparities. So I can talk forever, but I'll stop and see if there are any questions.
I have one question.
Mm-hmm.
So with the Medicaid, do you see any way to kind of like improve it? Do you see any challenges with Medicaid? I think one of the things that comes to mind when I think about it is the lower reimbursement rates,
Yeah.
and how does that affect access as well? Because I mean, of course, it's giving people coverage, but are they still able to go see a physician and maintain that if they just don't have a physician around them or a lot of physicians around them that will accept that?
Yeah, the provider participation is definitely an issue, and citing those low reimbursement rates has been one of the main reasons that you don't have every provider in the community participating in the program. But I think as people start to value this as health insurance, and buy into the program, so to speak, then you can look at increasing those reimbursement rates, so that more physicians will be incentivized to participate in the program. And it's really, a financial analysis that has to go into play here, because, even though there are some providers who may opt out of it, there are hospital facilities that can't opt out of serving patients that come to them, particularly in emergency situations. They have to treat those patients regardless of their insurance status. And so providing coverage to those people would help those hospitals to defray the costs and reduce their uncompensated care. And as that happens, then you can really balance out the lower reimbursement rates with having some steady, source of income that you can count on as a healthcare facility. So yeah, I think there are definitely things that could be done to improve the Medicaid program, specifically with the provider reimbursement rates, and also with the administration of the program. There's a lot of administrative costs that frankly could be reduced if the state would adopt smarter policies. Specifically, there's an annual renewal process. So people who are enrolled in Medicaid have to certify that they still qualify. Well, there are ways to certify someone still qualifies without the burden and the paperwork headaches that states often visit on these people, that they really have a hard time complying with because of all the other factors that are happening in their lives. But specifically in Tennessee, we had a mass disenrollment of over 100,000 kids off of our Medicaid program who still qualified. And it was all because their parents didn't return these paperwork that was sent to their houses. But we found through an open records request that a lot of those children never received the paperwork. There was never a determination that they actually did not qualify. They were disenrolled simply because they had not returned the information to show that they still qualified. But there are better ways to get that information than by sending packets to wrong addresses. Because we know that a lot of low income people tend to move more frequently than other people. And so our Medicaid agency did not have good addresses for a lot of those families, and they sent these packets out anyway. And when they didn't get them back, they cut the kids off, and that's a shame, really, because we know that most kids, would still qualify. If they no longer qualify for Medicaid, they would be able to move into our CHIP program, which is at a higher income cutoff. But instead, they just became uninsured. And we heard stories from families who would show up to a doctor's appointment or show up to a pharmacy to fill a prescription and then find out that they no longer had health insurance. That creates gaps in coverage, and it creates churn, because if this person is still eligible, they're going to reapply and get back on the program, and that costs the state money to have to process those applications and get people back on. That's what I mean by churn. And so in states that have burdensome administrative processes, they're spending more money on the churn, and that's something that could be reduced and redirected towards improving the program, like raising provider reimbursement rates.
I also wanted to ask a little bit. I don't know much about Medicaid. I know a little bit more about Medicare because that's what my grandparents use, and I studied that a little bit more. Mm-hmm. But could you, I guess, give some insight into like the process of how Medicaid is, like, I guess, utilized in the sense of like copays and deductibles? Are there any of those kind of conditions with that kind of coverage, or is it just like how does it work?
Well, it varies from state to state. Medicaid is a federal-state partnership, and so some of my more nerdy colleagues like to tell this joke that if you've seen one state Medicaid program, you've seen one state Medicaid program, because they all vary. So the federal government pays a certain percentage of the total cost, and the state kicks in the rest. And the federal government sets certain parameters in terms of eligibility, enrollment, and other key guidelines that the state has to follow, but the state has flexibility to do different things. And so in some states, there may be a copay. There may be cost sharing. In Tennessee, our Medicaid program does not have copays or cost sharing. So if you qualify, in most states, the core eligibility groups for Medicaid are low income seniors, families, or parents, children, and people with disabilities. And so it's not enough to just be low income. You have to fit in one of those categories. So when you think about a working childless adult, it doesn't matter how poor they are. They don't qualify for Medicaid in Tennessee. And I don't think they do in other states unless they've expanded. That's what Medicaid expansion is intended to cover, those childless adults and others who don't fit within those categories, but are still low income. And so the income cutoff can vary from state to state. The eligibility groups are typically the same. So when you talk about parents or caretaker relatives, children, older adults, and people with disabilities, that's the core Medicaid population. So if Medicaid is what's called an entitlement program. So that means if you qualify, you get to enroll. It's not capped. And there are no extra eligibility criteria that are supposed to keep people from being enrolled. But there has been an effort under the current administration to change the program and to make it dependent on work. So there's work reporting requirements that have been debated in recent years, and Tennessee is one of the states that has submitted a proposal to impose work reporting requirements. So that would be an extra kind of eligibility determination that would have to be made as to whether someone, if that requirement applies to them, because of course it wouldn't apply to children, it wouldn't apply to people with disabilities, it wouldn't apply to older people. So you're really just talking about parents and caretaker relatives. And the cost of administering a work reporting requirement program would offset the benefit. It just does not make sense. Like, when you do the calculations, it doesn't make sense. But that is another, feature that some states are exploring. And so far, courts have struck that down and said it's not legal. Medicaid is not a work program, it's a health insurance program. You can't tie Medicaid coverage to work. And so that's something to kind of be on the lookout in terms of how states are doing their Medicaid programs. Did that answer your question?
Yeah, no, it did definitely. Yeah, we're talking a lot about it, and I've never really kind of looked into how it's really carried out, because I know, like, I'm from Georgia, and I know the SNAP program that they have there. It's like you have to work, the employment tied to their or a contribution from their employment taxes. So I was wondering if Medicaid was similar in that sense.
Yeah, no, not yet. And hopefully, if the courts can keep making smart rulings, then no state will be allowed to impose that requirement in our Medicaid program. But yes, SNAP is an example of a public benefit program that does have a work requirement in most states. And for those who may not be familiar, SNAP is formerly known as food stamps. Are there any other questions? One other thing that I wanted to mention that I thought was pretty cool is that back in the 1940s, when President Truman first proposed a national healthcare program, the American Medical Association was one of the outspoken opponents to doing that, and they defeated that effort to create a universal healthcare system. Efforts were made later on in the 50s to bring about Medicare and Medicaid. And at that time, the AMA again stood up and said, no, this is socialized medicine. This will disrupt the doctor-patient relationship. It's a bad idea. You don't want to do it. But the National Medical Association, NMA, stepped up and said, no, we're gonna counter this propaganda and really give people the facts about, why it's a good idea to provide health insurance to people. And they were able, to help bring about that victory of getting our current Medicare and Medicaid programs implemented. So shout out to the NMA for the great work that it's done over the years to ensure that people have access to health care.
Any other good questions? Thoughtful questions? You look like you got one, Becky.
Not really. Just because you were talking about like a policy angle and then more Black physicians, like, is there a policy that could help push things in that direction, or will that just be like slowly institution based?
I think with the racial reckoning that's happening in our country, that that's something that can happen with philanthropic efforts to make it to make medical school more accessible to Black people. So, for example, Michael Bloomberg just made a huge donation to Meharry Medical College, which is a historically Black college here in Nashville, one of the oldest medical schools for Black people. And so that money is being used to provide scholarships to those medical students. I think finances and money is the key issue in terms of increasing the number of Black physicians in this country. So as more people see fit to support Black students who may not be able to afford to go to medical school, then you'll have more Black doctors matriculating and going out and practicing and giving back to the community in that way. I think the government could play a role in that. They could create different loan forgiveness programs for doctors who go and work in underserved communities, and that's something that may be of interest to Black doctors, and that's something that they could take advantage of. But yeah, I think there are definitely ways to incentivize it and to help more Black people become doctors, but it kind of depends on that financial piece.
Thank you.
Sure. Well, thank you guys so much for having me. Please check out the paper. There's lots of great content on our website on the health equity page. And you can definitely be in touch. I'll provide my email address to everyone. So if you have any questions, you can reach out to me. And if I don't know, I can probably put you in touch with someone who does.
Okay, thank you so much. If we don't have any more questions, we're good. Yeah, thank you so much. And if in the future, if you're willing to come back and speak on some of the updates in Tennessee, I think we would love that. And just kind of keep track with that progress and see where our country's going.
Great. One other thing I forgot to mention is there's a digital vigil that's happening on October 1st at 6 p.m. Central, 7 Eastern. And you can learn more about that at this website that I'm putting in the chat. Hopefully it is the right one. Stacey Abrams is going to be hosting, and Reverend Dr. William Barber is the keynote speaker. So I encourage you to check that out and learn more about the different Southern states and their efforts to expand Medicaid. So that includes Tennessee, Texas, Alabama, Georgia, Mississippi, Florida, North Carolina, and South Carolina. So thanks, everybody.
Thank you. Bye. Have a good one.